Good morning, dear students. My name is Olpol Hanfisenko. Today's topic of our lecture is fluid electrolyte and acid-base misbalances. We'll cover the next objectives: water content in human body, fluid sectors, fluid balance regulation, main electrolytes, osmolarity, hyperhydration states, algorithms of fluid therapy, main buffers in human body, and acid-base analysis. What is the water content in human body? In fetus, water content is about 85%, and the baby at birth has 75% of water. Normally, in men, it's about 60%, in women, 50%, but aged patients has less water, about 45%, and babies are like bags of water. Fluid sectors or compartments. There are two main fluid sectors in human body. Intracellular fluid, it's about 40% of body mass or 28 liters totally. And extracellular fluid, it's about 20% of body mass, about 14 liters, but it's divided into two parts. Intravascular fluid, about 3 liters or 5% of body mass, and interstitial fluid, 15% of body mass or about 11 liters. There is a connection between interstitial and intravascular fluid through the lymph. What is the border between these fluid compartments? Between extracellular and intracellular fluids, there is a cell membrane, and between interstitial and intravascular sector, there is a capillary membrane. Changes in fluid compartments with age. During the first year of life, there is a decrease in total body water due to decreased extracellular fluid, but intracellular sector increases. But after the 1 year of age, during the life, there is a little changes in fluid compartments. Interstitial space. It's not empty space. Fluid is located in form of gel, but in excess of water in interstitial space, maybe there is a formation of rivulets of free fluids, free fluid vesicles. Normally, the pressure in interstitial space slightly negative, about -4 millimeters of mercury column, but in excess of water, edema formation, this pressure can increase rapidly, compressing capillaries and leading to impaired microcirculation. Expanded fluids in compartments. Fluids used for fluid therapy expands between compartments following way. Free water solutions, it's mainly dextrose solutions, freely pass through the capillary membrane and cell membrane, so free water expands in all fluid sectors. Saltwater electrolyte solutions, they freely pass through the capillary membrane, but not through the cell membrane, so they expand into intravascular and interstitial sector. Colloid solutions mainly collect in intravascular sector through the intact capillary membrane. Colloids, synthetic colloids cannot pass freely. Some terminology points. When you say about osmolarity, we use osmotic concentration of substances. 1 mole of a substance contains such number of elementary entities of that substance. And osmol is used when the actual number of osmotically active particles present in solution is considered. Millimole of sodium chloride, which dissociates nearly completely into sodium and chloride, contributes 2 milliosmoles. What is osmolarity and osmolality? Osmotic pressure is dependent only on the number of particles of solute per unit of solvent and not on the chemical or physical properties of particles. Osmolarity denotes the number of particles of a solute per volume of solvent, milliosmoles per liter. Osmolality denotes the number of particles of a solute per weight of solvent, milliosmoles per kilogram. For most biologic fluids, the numerical difference between these two is negligible. In plasma, number of cations and number of anions are equal. Laboratory detection of osmolarity is quite complex procedure, so very often the osmolarity is calculated by the formula, using next formula. Sodium and potassium in plasma concentrations taken together multiplied to 2 and plus glucose and urea. When glucose and urea, all the things taken in millimoles per liter. Normally plasma osmolarity is 285 plus minus 10 millimole per liter. Diagram by Gamble, it's called in anesthesiologic jargon gamblegram, demonstrates the number of cations and anions in plasma in extracellular fluid. It's the same for interstitial fluid too. You can see that on cation side from 150 millimole per liter, more than 140 it's the sodium, and a very small amount of potassium, calcium and magnesium. They are called non-measured cations. On the anion side, 2/3 of anions, it's chloride anion, and 1/4 is bicarbonate, and there is other anions, about 26 millimole per liter. This is the cations and anions in extracellular and intracellular fluid. You can see that sodium is the main extracellular cation, potassium intracellular. Magnesium mainly located intracellularly and calcium extracellularly. Chloride mainly extracellular fluid, phosphate, organic anions in intracellular fluid. Bicarbonate mainly extracellular and proteins mainly intracellular. Regulation of fluid electrolyte balance in human body. There is separate regulation of osmolarity of extracellular fluid and volume of extracellular fluid. Osmolarity of extracellular fluid is regulated by antidiuretic hormone. Another name is vasopressin or arginine vasopressin. You know that this hormone is secreted in hypothalamus, then it enters to hypophysis. From the hypophysis, it enters in circulating blood. With the blood is taken to kidneys, and at the distal part of nephrons there is aquaporinic channels are sensitive to action of antidiuretic hormone. And the main action of antidiuretic hormone is the reabsorption of free water. On this slide, on the green part, you can see osmotic regulation of antidiuretic hormone secretion in normal stage. And on the red side, you can see some problems you can meet in your patients in pathological status. So, when osmolarity of plasma increases, this stimulates the feeling of thirst and stimulate patient to drink water. But unconscious patients cannot intake fluids through the thirsty. Normal secretion of antidiuretic hormone takes place on plasma osmolarity from 280 to 300 milliosmoles per liter, but osmoreceptors of hypothalamus react to osmotic shift in 1 or 2%. If the osmolarity of plasma decreases below the level 280 milliosmoles per liter, ADH secretion stops. And when osmolarity is more than 300 milliosmoles per liter, ADH secretion increases rapidly up to 20 times. But this process can be changed in some pathological or even in pregnancy. It's called reset osmostat. In pregnant women, normal secretion of ADH takes place when osmolarity of plasma 260 up to 280 milliosmol per liter. In such way, pregnant women collect deposit water preparing for delivery. In some pathological states such as tumor or trauma in hypothalamus region, osmostat can be changed when normal secretion of ADH takes place with plasma osmolarity 300-320 milliosmol per liter. Normally, aquaporinic channels of distal nephron are highly sensitive to ADH that reabsorb free water. But this sensitivity can be changed. They can be partly sensitive or fully unsensitive to the action of antidiuretic hormone. Except osmotic stimulation, there is non-osmotic regulation of ADH secretion. Signals from baroreceptors of carotid, aortic region, from volume receptors of atrium can provide some influence on ADH secretion in hypothalamus. So, decreased blood pressure increases secretion of ADH, and conversely, increased blood pressure decreases secretion of ADH. Hypovolemia, the decrease in circulating blood volume more than 10-15% rapidly increase the secretion of antidiuretic hormone, and even body position provide influence on ADH secretion. Many other things such as nausea, vomiting, hypoxia, and many medicaments provide influence on antidiuretic hormone secretion. Effects of extracellular fluid osmolarity shift on cells. When osmolarity of extracellular fluid is normal, this situation we call isotonic situation, the cell volume doesn't change. But in hypertonic state, hypertonicity of extracellular fluid, water moves from cells into the interstitial space, and this can lead to cell shrinking. In hypotonic extracellular space, water moves into cells, providing cell edema that can lead to cell damage. Regulation of volume of extracellular fluid. It's the responsibility of renin-angiotensin-aldosterone system. This system is quite complex. It includes the function of many other organs as mafia. So, decreased blood volume, hypovolemia, decreased arterial pressure, stimulate the secretion of hormone renin in juxtaglomerular apparatus in kidneys. Liver synthesize angiotensinogen. Renin convert angiotensinogen to angiotensin I. Lungs provide secretion of converting enzyme that convert angiotensin I to angiotensin II. So finally, angiotensin II is active substance. What is the action of angiotensin II? It has direct action on blood vessels, providing vasoconstriction, increasing blood pressure. It stimulates the secretion of aldosterone in adrenal cortex. Aldosterone reabsorbs sodium in kidneys, restoring blood volume. Angiotensin II has direct effect on brain, providing increased secretion of antidiuretic hormone that reabsorb free water. And angiotensin stimulate the feeling of thirst, making the patient drinking water. So all these mechanisms are for the restoration of circulating blood volume. There are antagonistic system of renin-angiotensin and aldosterone system. It's natriuretic peptides. The signals from baroreceptors and volumereceptors in hypervolemia stimulate natriuretic peptide synthesis in atrium. Natriuretic peptides antagonize the effect of angiotensin II. They decrease aldosterone secretion, decrease sodium reabsorption, and increase glomerular filtration rate and stimulate diuresis. Fluid shift through the capillary membrane early was described using Starling forces. It was considered that at the arterial end of capillaries there is filtration processes, and at the venous part of capillaries there is reabsorption of fluid from interstitial space into capillaries. So the rate of such filtration about 20 liters per 24 hours in adults. And this fluid mainly returned to venous system through the lymph. So recently, Starling equation was revised. The classic Starling principle does not hold the fluid resuscitation in clinical settings. The endothelial Glycocolyx layer appears to have a major role in fluid exchange. A revision of Starling incorporating the Glycocolyx model appears to explain better the responses seen clinically. The characteristics of capillaries in various tissues are reviewed and some clinical corollaries considered. The oncotic pressure provided by albumin difference across the endothelial gel layer opposes but does not reverse. So the filtration rate, the no absorption rule, and is an important feature of the revised paradigm and highlights the limitations of attempting to prevent or treat edema by transfusing colloids. Filtered fluid returns to the circulation as lymph. The glycocalyx is located on the apical surface of vascular endothelial cells which line the lumen. What is the role of glycocalyx? Regulates vascular permeability and the fluid balance due to the large size and negative charge of its glycosamine glycans. Provides the physical barrier against inadvertent adhesion of platelets and leukocytes to the vascular wall. Regulates coagulation as many of mediators of coagulation pathway are buried inside the glycocalyx under normal physiological condition. Functions as a mechanosensor and transducer of the shear force inside blood vessels to regulate the synthesis of nitric oxide in response to the blood flow. Many factors can affect endothelial glycocalyx layers such as sepsis, stress, anaphylaxis, hypervolemia, using synthetic colloids for infusion therapy. In such cases, damaged glycocalyx can lead to capillary leakage. In pathophysiology of COVID-19, there is big role of endothelial glycocalyx layer damage. Main cations. Sodium. It's the main cation of extracellular fluid. You can see concentrations in cells and in plasma. In plasma, 135, 145 millimole per liter normally. Sodium contributes major osmotic pressure of body fluid. Sodium and potassium together produce cell membrane potential. Dehydration states. They may be isotonic, hypertonic, and hypotonic. Isotonic dehydration. Synonyms: hypohydration with normal sodium, isoosmolar water deficit. Causing factors: losses from digestive system such as vomiting, diarrhea, bleeding, burns, isostenuria, losses into the third compartment. Pathophysiology. There is equal hypohydration of both compartments, intracellular and extracellular. Clinical signs: decreased skin turgor, dry mucous membranes, decreased blood pressure, central venous pressure, tachycardia, oliguria, and the mild thirst. Treatment options: it's the administration of isotonic fluids. The first stage is a quick fluid resuscitation for restoration of circulating blood volume, but after restoration of blood volume, you must decrease the speed of infusion. Hypertonic dehydration. Synonyms: hypohydration with hypernatremia, hyperosmolar water deficit. Hypernatremia is indicative of fluid depletion. The loss of free water is more than the loss of electrolytes. Causing factors: insufficient drinking of water in psychopathology in unconscious patients, increased insensible losses of water, increased sweating, hyperventilation, diarrhea, polyuria in patients with acute renal insufficiency, diabetes mellitus decompensation, burns, and heat shock. In pathophysiology, there is hypernatremia that leads to hypohydration of intracellular space. Clinical signs: thirst due to hypohydration of cells, decreased skin turgor, dry mucous membranes, tachycardia, orthostatic hypotension, oliguria, and sodium in plasma increased. Treatment options: you should avoid rapid and extreme changes in serum sodium concentration. It's safer to change serum cautiously. Start with normal saline containing sodium at a range of 154 mmol per liter for the initial correction of hypovolemia. Then you can change to dextrose solutions to replace water and slowly correct sodium concentration. Hypotonic dehydration. Synonyms: hypohydration with hyponatremia, hypoosmolar water deficit. Causing factors: high volume pancreatic fistula, biliary fistula, using of diuretics, Addison's disease, sodium losing nephropathies, gastrointestinal losses, diarrhea, vomiting, and fluid sequestration in peritonitis and pancreatitis. Pathophysiology: extracellular dehydration with intracellular hyperhydration. Clinical signs: the thirst is absent, decreased blood pressure, and signs of brain edema such as apathy, stupor to coma. Treatment options: you can start with normal saline and restore sodium deficit according to the formula can be calculated. Dehydration states mainly in 80% of cases isotonic, in 50% of cases hypertonic, and really in 5% of cases hypotonic. There is a severity rate of dehydration according to the volume of water deficit in percentage from total body fluid and in liters. And deficit more than 10 liters of fluid in adults, it's non-compatible with life. Clinical signs of dehydration in children, you can see here. And in small children, you can see sunken fontanella. You can calculate electrolyte deficits using this formula, body mass in kg multiplied to 0.2, it's 20% of extracellular water and difference of the concentration of electrolyte in patients from normal range. So you can take this deficit in millimoles. And using these equations, you can calculate the number of milliliters per solution to restore such electrolyte deficits. Hyperhydration states: They can be also isotonic, hypertonic, and hypotonic. Isotonic hyperhydration, synonyms: hyperhydration with normal sodium, isoosmolar water excess. Causing factors: it's incorrect infusion therapy with a big amount of normal saline, chronic heart failure, glomerulonephritis, corticosteroid therapy, Cushing disease. In pathophysiology, there is a hyperhydration of extracellular fluid. Clinical signs mainly peripheral edema. Treatment options include treatment of underlying causing factors, maybe diet with sodium restriction and using diuretics. Hypertonic hyperhydration, hyperhydration with hypernatremia, hyperosmolar water excess. Causing factors: incorrect infusion therapy with a big amount of hypertonic saline or sodium bicarbonate. In pathophysiology, cell dehydration with hyperhydration of extracellular fluid. Clinical signs: thirst and increased sodium in plasma. Treatment options include administration of loop diuretics and maybe infusion of glucose solutions. Hypotonic hyperhydration. Hyperhydration with hyponatremia, hypoosmolar water excess. Causing factors: incorrect infusion therapy with a big amount of glucose in patients with oliguria, incorrect dosing of loop diuretics, and inappropriate antidiuretic hormone secretion. This situation can be caused on the basis of many causing factors, including some tumors that can provide ectopic secretion of antidiuretic hormone. Pathophysiology: total hyperhydration, extra and intracellular. Clinical signs: it's mainly signs of brain edema. And the treatment options include hypertonic sodium solutions. If the patient has signs of chronic cardiac insufficiency, maybe you can use diuretics in treatment of hypotonic hyperhydration. Plasma sodium is very essential for brain function. Blood-brain barrier is freely permeable for water but not for sodium. Thus, the brain volume is dependent on plasma sodium level. So, as well as increased and decreased plasma affect brain function. Brain capillaries are different from capillaries in other tissue. First of all, the place contacts between endothelial cells in brain capillaries are saturated tightly by fibrous fibers. It's called tight junctions. There is no pores in these endothelial cells in brain capillaries. Number of pericytes covering outside surface of capillaries in brain several times more than in another capillaries, so substances to enter to pass blood-brain barrier to enter from blood to neurons should pass through the body of endothelial cells, through the body of astrocytes, and only after passing this blood-brain barrier enter to neurons. Sodium correction must not exceed 8 millimole per 24 hours because rapid onset of acute hypernatremia as well as rapid correction of chronic hyponatremia can lead to rapid increase in plasma sodium concentration resulting to osmotic demyelination syndrome. On the other side, rapid onset of acute hyponatremia as well as rapid correction of chronic hypernatremia can lead to rapid decrease in plasma sodium concentration, leading to cerebral edema with uncal herniation. When you say here chronic, you mean The duration of the process about 48 hours. Another cation is potassium. It's the main intracellular cation. Concentration in cells quite high, in plasma 3.5 up to 5.3 millimole per liter. Potassium contributes to intracellular osmotic pressure, provides potential across nerve cells, activates enzymes including phosphorylases. Potassium imbalances, hypokalemia, causing factors mainly decreased intake, adrenal cortex hyperfunction, and diuretic therapy. In alkalosis, potassium shifts from plasma into cells, and the loss of potassium due to vomiting, gastric suction. Clinical manifestations are mainly cardiac arrhythmia, lower T wave, and appearance of U wave due to slow repolarization and muscle weakness. Hyperkalemic states, causing factors, increased intake or renal failure, or hypoaldosteronism. In acidosis, potassium shift from cells into plasma, and the hemolytic status. Clinical manifestations of hyperkalemia, cardiac depression, shallow wide QRS with elevated peak T waves due to exaggerated repolarization, paresthesia, and paralysis of muscles. Here you can see ECG signs of hypokalemia and correction of hypokalemia. If it's possible, it's better to provide oral replacement of potassium deficits. If it's impossible, intravenous replacement. But maximum concentration through the peripheral vein may be infused. It's 60 milliequivalent per liter. Maximum rate of administration potassium chloride should be 0.3 milliequivalent per kilogram per hour, or 40 milliequivalent totally per hour, whichever is less. ECG signs in hyperkalemia. Correction of hyperkalemia, you should obtain ECG monitoring, stop all intakes of potassium. In severe cases with potassium more than 7 millimole per liter or abnormal ECG, you should protect myocardium using calcium preparations, sodium bicarbonate, and glucose with insulin that pushes potassium from plasma into cells. You can use beta-2 adrenomimetics for this goal and prepare for hemodialysis in life-threatening arrhythmias. Next cation is calcium. It's mainly extracellular fluid cation. Concentration in plasma about 2.5 millimole per liter. Calcium affects permeability of cells, possibly involved in sodium pump action, involved in muscle contractions through activation of myosin enzyme. Imbalances of calcium, hypocalcemia, causing factors, decreased intake, vitamin D deficiency, hypoparathyroidism, hypoalbuminemia, alcohol abuse, and liver failure. Clinical manifestations, increased neuromuscular activity, possible convulsions, and skeletal muscle tetany. Hypercalcemia, causing factors, increased intake, immobility, hyperparathyroidism, bone malignancies, and renal failure. Clinical manifestations, decreased neuromuscular activity, stupor to coma, formation of renal calculi, increased fracture risk. There is a severity and the treatment options for hypocalcemia. You can use preparations such as calcium gluconate or calcium chloride, and combined treatment with calcium supplements and vitamin D. And severity and the treatment options for hypercalcemia. Elimination of cause increases urinary excretion and decreased intestinal absorption using dietary phosphate increasing and glucocorticoids, and decreased bone reabsorption using calcitonin, biophosphates, and severe cases may be used dialysis with calcium-free dialysate. Next cation is magnesium. It's mainly intracellular cation. The concentration in plasma is about 1 millimole per liter. It decreases permeability of membranes but otherwise acts contra-osmotically to calcium. It decreases excitability of muscle. Phosphates. They present mainly in intracellular sector in plasma concentration about 1.4 millimole per liter. Phosphates serve as buffers in acid-base balance, the source for 2,3-dephosphoglycerol, ATP, creatinine phosphate, etc. Bicarbonate. It's mainly extracellular buffer. In plasma, concentration normally about 24 millimole per liter. And bicarbonate is the main form of transportation of CO2 from tissues to lungs. Fluoride, main anion of extracellular fluid, in plasma concentration about 103 millimole per liter. Fluoride affects cell membrane permeability, balances cation concentration within cell. Fluid balance. This is the rate of exchange of fluids between human body and environment. Normally, we intake fluid with beverages, solid water, and there is a small amount of water, about 4 milliliters per kg per day. It's called metabolic water due to oxidation processes. And the main losses of water with urine, there is insensible losses of water through skin and respiratory tract, about half liter each per day normally. Daily fluid balance. In normal, there is equal intake and loss of water, so fluid balance is zero. In newborns and infants, it can be slightly positive. We say positive fluid balance when intake more than losses, and a negative fluid balance when losses more than intake. There is gastrointestinal fluid circulation about 8-9 liters per day, so you cannot calculate fluid balance correctly up to milliliters. It's only approximately calculation. There are several guidelines on fluid therapy. I recommend you to use NICE guidelines, British National Institute for Health and Care Excellence. They are available on their website for free. This is algorithms of fluid therapy from these guidelines. They regulate indications for fluid therapy according to the rule 4R. So, fluid is considered to be used as any other medicaments. So, according to the indications, the first indication for fluid therapy is resuscitation, mainly in shocked patients, restoring circulating blood volume. The next indication is routine maintenance, supplying the patient with normal physiological requirements in fluids. Next R is replacement of pathological losses, and the last R indication for fluid therapy, it's a redistribution problems, quite complex problems. Mainly it's the responsibility of anesthesiologists. And there is a fifth R, reassessment of the state of patients during providing fluid therapy. It's very essential too. So, assessing the patient needing fluid therapy, you must check for hemodynamic parameters. If there is a systolic blood pressure less than 100 millimeters of mercury column, heart rate more than 90 per minute, capillary refill time longer than 2 seconds, and cold peripheral in touch, respiratory rate more than 20 per minute, assessment according to the early warning score more than 5 points, and passive leg rising up to 45% suggests fluid responsiveness. It means that the patient needs fluid resuscitation. Of course, you can take some history, anamnesis, previous limited intake, thirst, abnormal losses, comorbidities, clinical examination, laboratory testing, some monitoring. In laboratory testing, there is useful information you can find in full blood count, especially hematocrit and the hemoglobin rate, showing hemoconcentration, concentration of urea, creatinine, and electrolytes. So all these things help you to define if your patient needs fluid resuscitation. If the patient needs resuscitation, you should use crystalloid solutions containing sodium at the range 130–154 millimole per liter, 500 ml less than for 15 minutes. Such boluses you can repeat 4 times. When you reach 2 liters totally, you should seek expert help. Experts are anesthesiologists. The next indication for fluid therapy is routine maintenance. In adult, it can be calculated. It's about 25–60 milliliters per kilogram of ideal body mass per day for 24 hours, and this volume must contain at least 1 millimole per kilogram per day, sodium, potassium, and chloride, 1 millimole of each of these electrolytes, and from 50 to 100 grams per day glucose. The next indication for fluid therapy is replacement of pathological losses. In this slide, you can see the content of main ongoing losses for adult patient from different parts of gastrointestinal system. You can see all of them contain very big concentration of sodium, potassium, bicarbonate, chloride. So you must restore all these pathological losses. This is the algorithm for fluid therapy in children. Nice algorithm, or young people up to 16 years of old. It's mainly the same as for adults, but with some differences. For example, in children, there is a very big accent on risk of hypoglycemia. In fluid resuscitation, it's recommended to use the same crystalloid solutions, contain sodium in the range 131–154 millimole per liter in bolus, 20 milliliters per kg. You can repeat such boluses 3 times. When you reach 60 milliliters per kg, you must seek expert consultation. For routine maintenance in children, you can use the formula by holiday cigar 4-2-1 rule, but if the patient has some problems, cardiac problems, renal problems, it's better to calculate requirements in fluids per body surface, 300–400 ml for square meter for 24 hours plus urinary output. These guidelines recommend to use isotonic solutions for supplying routine maintenance at the beginning. Then you can use another hypotonic solutions according to the electrolyte deficits. There is requirements in fluid for newborns for first days of life. Replacement and redistribution problems. Recommended use of isotonic crystalloids for redistribution problems. You can start with normal saline. There is algorithm for correction of hypernatremia in children. If there is volume deficit in hypernatremia, first of all, using normal saline, you must restore circulating blood volume. After this, you can use hypotonic, half normal saline, and glucose solutions. And management of hyponatremia in children depends on the presence or absence of symptoms of brain edema. In presence of symptoms, you should use hypertonic sodium chloride solutions. In the absence, you can start with normal saline. This is a diagram of ongoing losses for children and young people, mainly the same content of losses as in adult. Intravenous fluid administration. There are two main classes of intravenous fluids, colloids and crystalloids. Colloids have big molecules. Only natural colloid is albumin. Synthetic ones, dextrans, gelatins, and hydroxyethyl starches. Molecular weight reaches on hundreds and thousands of Dalton. Crystalloids, such as electrolyte solutions and dextrose as free water, has very small molecular sizes, up to 600 Daltons. Advantages of colloids: less volume needed for restoration of circulating blood volume, prolonged volemic effect, and less peripheral edema formation. But there are more negatives of colloids. They are more expensive than crystalloids. Pulmonary edema in case of capillary leakage can develop in colloid administration. Synthetic colloids can cause nephrotoxicity, coagulopathy, and allergic problems. Crystalloids advantages: they are less expensive than colloids. They enhance renal perfusion and interstitial volume replacement. And negatives: short volemic effect, peripheral edema formation, especially in hypoalbuminemia, and pulmonary edema formation in hypoalbuminemia and high pulmonary capillary pressure. This is the contents of main crystalloid solutions in comparison with plasma content and osmolarity of such solutions. When crystalloid solutions contain the same electrolytes and buffers as plasma, they are called balanced solutions. Albumin is only natural colloid. There is a transcapillary escape rate of albumin normally 4-5% per hour. If you multiply to 24, you can take that all albumin leave intravascular sector, move to interstitial sector to take place its role in metabolism, but in the same rate with lymph, albumin returns to venous system. With increased capillary permeability, with damaged glycocolyx, when there is a capillary leakage syndrome, the transcapillary escape rate of albumin increases several times, but returning through the lymph cannot be increased. In such cases, there may be formation of severe interstitial edema, pulmonary edema. That's very difficult to treat. Acid-base balance. The ratio of hydrogen cations to different anions. Maintaining the optimal level of acid-base balance of body fluids is a necessary condition for normal metabolism and enzyme activity. We determine the acid-base balance of plasma, and it's the same for all extracellular fluid. Only God knows what is going on in the cells. Concentration of hydrogen ions in C system is taken in nanomole per liter, and we use pH. Potential hydrogeny, it's the negative decimal logarithm from the concentration of H ions. In neutral solution, pH is 7. In human body, in extracellular fluid, pH is 7.4, so we have some alkaline reserves. We are more protected from acidosis than from alkalosis. So, in human life, many dangerous situations are acidotic attacks. Here you can see the pH and H ion concentrations in different body fluids. Extracellular fluid, arterial blood 7.4, venous blood 7.35, interstitial fluid 7.35, intracellular fluid from 6 to 7.4, urine from 4.5 to 8, and gastric juice has pH 0.8. Changes during intake of food or under the influence of some medicaments. In some cases, we increase pH of gastric juice using sodium channel blockers or H2 histamine blockers for the goal of decreasing the rate of aspiration. Buffers in human body. The main buffer is hydrocarbonate buffer. It's more than half of body buffers potency. Hemoglobin 35%, protein 7%, mainly intracellularly, and phosphate buffers 5%, they mainly functioning in kidneys. So when analyzing acid-base balance, we analyze the role of hydrocarbonate buffer. How does it work? Carbonic acid on one side can dissociate into CO2 and water. CO2 can be excreted or retained through lungs. It's called respiratory component. On the other side, carbonic acid can dissociate into H ions and bicarbonate. Both can be excreted or retained. Bicarbonate may be synthesized in kidneys. So this part is called metabolic component. Henderson-Hasselbalch's formula. When you have partial pressure in arterial blood with CO2 and concentration of bicarbonate ions, you can calculate concentration of H ions. Having concentration of H ions, we can detect pH. Laboratory tests for acid-base balance. It's called arterial blood gases. Partial pressure of oxygen in arterial blood. Normally in young patients it's 80 up to 100 millimeters of mercury column when breathing air, but it decreased with age. And when it's decreased, there is hypoxemia develops, and the severity of hypoxemia given here. pH normally 7.35, 7.45, less than 7.35 it's acidosis, more than 7.45 alkalosis. Partial pressure of CO2 in arterial blood 35-45 millimeters of mercury column, less than 35 respiratory alkalosis, more than 45 respiratory acidosis. Bicarbonate. In this analysis, there is two types of bicarbonates, actual bicarbonate and standard bicarbonate. Actual bicarbonate It's about 20-25 millimole per liter normally. It's measured concentration of bicarbonate ions in blood sample. What is standard bicarbonate? Normally it's about 24 millimole per liter. It's the concentration of bicarbonate ions in standardized condition. Standardized means PaCO2 40 millimeters of mercury column, temperature 37 centigrade, and full saturation of blood with oxygen and water vapors. This condition provided to eliminate the influence of PaCO2 on the level of bicarbonate. body buffers, normally from 40 to 60 millimeters per liter. It's the total potency of all body buffers. And BE, base excess or base deficit, it's the difference of potency of total body buffers in patients and from normal. For normal taken about 40, lower limit. And normally base excess from +2 up to -2 through the 0. Plus indicates base excess and minus indicates base deficit. pH. In different solutions, it can change from 1 up to 14. But in our body, pH restricted in such very small area. 7.35, 7.45, it's normal or compensated state. 7.35, 7.29, subcompensated acidosis. 7.29 up to 6.8, decompensated acidosis, and less than 6.8, it's incompatible with life. On alkaline side, 7.45, 7.56, subcompensated alkalosis, 7.56, 7.8, decompensated alkalosis, and more than 7.8, incompatible with life. There is no specific clinical signs for acidosis and alkalosis. In all cases, you can see on the patient the signs of causing state or disease. But mainly, acidosis is associated with CNS depression, and alkalosis is associated with hyperexcitability of central nervous system. The changes of main laboratory data in respiratory and metabolic acidosis and alkalosis. Respiratory acidosis, pH goes down. The main respiratory component, PCO2, increases. Bicarbonate at the beginning may be normal, but if the situation lasts more than 2 days, kidneys start to retain bicarbonate, to synthesize bicarbonate, so its concentration in plasma increases. It's renal metabolic compensation of respiratory acidosis. Respiratory alkalosis, pH increases, PaCO2 decreases, and if the situation lasts longer, bicarbonate, the kidneys start to excrete bicarbonate, so its concentration in plasma decreases. In metabolic acidosis, pH decreases, the main metabolic component, bicarbonate, decreases in plasma. It's a deficit of bicarbonate. And respiratory component start to compensate immediately because the level of pH can influence on respiratory center. The patient start breathing rapidly, so eliminate CO2, so its concentration decreases. It's a respiratory compensation of metabolic acidosis. Metabolic alkalosis, pH is going up, bicarbonate increases, it's excess of bicarbonate, And respiratory compensation, the patient provides bradypnoea, breathing, decreasing the frequency of respiratory rate and the volume of respiration. So there is a increased PaCO2. To better remembering these directions of shifts laboratory tests in acid-base imbalances, there is a mnemonic Rome, respiratory opposite, metabolic equal. What does it mean? In respiratory disbalances, the direction of shifting pH and the main respiratory component PaCO2 in the opposite direction. In metabolic imbalances, the direction of changes of pH and the main metabolic component bicarbonate in the same direction, so metabolic equal. Correction. It's the influence on affected component of acid-base balance, and compensation when you influence on intact component to compensate this balance. So how to read analysis of acid-base balance? When you have pH, we detect, is it normal or changed? If it's decreased, we say acidosis. If there is decreased bicarbonate, it's metabolic acidosis. If the patient has decreased PaCO2, we see respiratory compensation of metabolic acidosis. If in acidotic state PaCO2 increased, this acidosis is respiratory. If there is increased bicarbonate, it's renal compensation of respiratory acidosis. In case of increased pH, it's alkalosis. If there is excess of bicarbonate, it's metabolic alkalosis. And if PaCO2 increases, it's respiratory compensation of metabolic alkalosis. In alkalotic patient, if there is decreased PaCO2, it's respiratory alkalosis. If there is decreased bicarbonate, it's renal compensation of respiratory alkalosis. So respiratory acidosis, it's excess of CO2. Causing factors may be many different things. Respiratory center depression, airway obstructions, lung diseases, some myopathy, all things that can lead to hypoventilation, increased CO2 and H ion concentrations leading to respiratory acidosis. And in respiratory acidosis, potassium shift from cells to plasma, and such hyperkalemia can lead to arrhythmias, including ventricular fibrillation. What to do in respiratory acidosis? Reasonable correction to normalize ventilation, and the stupid compensation is infusion of bicarbonate. Respiratory alkalosis, it's a deficit of CO2. Many factors such as agitation, hyperthermia, pain, respiratory center irritation, encephalitis, hyperthyroidism, gram-negative sepsis lead to hyperventilation, decreasing CO2 and H ion concentration, and to the formation respiratory alkalosis. What to do in respiratory alkalosis? Reasonable correction to treat the cause of hyperventilation. So the management of the patient will be very different according to the causing factor. For example, if hyperventilation caused by hyperthermia, you use antipyretics. If the causing factor is pain, analgesics. If the patient is in agitation state, you use sedatives. So treatment differ according to the causing factor. Metabolic acidosis, it's bicarbonate deficit. Causing factors may be two groups of causing factors. The first one is excessive production of organic acids. In shocked states, decompensated diabetes mellitus, renal failure, lactate acidosis, alcohol poisoning, salicylate overdosing. Another group of causing factors: bicarbonate losses in diarrhea and fistulas, bile or intestinal fistulas. All these things can lead to excess of organic acids and deficit of bicarbonate. Decreased bicarbonate lead to formation of metabolic acidosis. What to do in metabolic acidosis? Bicarbonate administration seems to be the most rational therapy. However, this can cause the so-called overshunt, which will lead to metabolic alkalosis, the treatment of which is much more difficult than metabolic acidosis. Bicarbonate is indicated when pH less than 7.2. There is a risk of arrhythmia and brain injury. Dosing of bicarbonate, you can use the formula. Molar concentration 8.4% of solution contain 1 millimole in 1 milliliter. So the need in milliliters of bicarbonate 0.2 multiplied to body mass in kg multiplied to base excess in millimole per liter. In all cases, you should treat the cause. Do not stop the compensatory hyperventilation in patients in metabolic acidosis. It keeps pH above dangerous level 7.2. And treating the causing factor will be different. In lactic acidosis in shocked patients, the main management is hemodynamic stabilization, improving organ perfusion. In ketoacidosis, you can use insulin therapy at the beginning. Then you can use glucose infusion of bicarbonate. Calculation of plasma anion gap can help you to define the causing factor in metabolic acidosis. There is a formula for calculation anion gap. Sodium minus bicarbonate minus chlorate, it's approximately 10 milliequivalent millimole per liter. If anion gap increases, the metabolic acidosis is called normochloremic, and the cause of such acidosis may be ketoacidosis in diabetes mellitus decompensation, lactic acidosis on the basis of shock states, chronic renal failure, aspirin poisoning, methanol, ethylene glycol, alcohol poisoning, and starvation. In normal anion gap metabolic acidosis, it's called hyperchloremic acidosis. It may be due to diarrhea, renal tubular acidosis, and a side effect of carbonic anhydrase inhibitors, diuretics, and Addison's disease. Metabolic alkalosis. It's a bicarbonate excess, gastric juice loss, vomiting or gastric lavage, excessive base intake, massive transfusions, intestinal fistula, hypokalemia, Cushing syndrome, hyperaldosteronism, diuretics can lead to loss of acids and H ions, or excessive bicarbonate or lactate intake per os or intravenously. All these things provide excess of bases and formation of metabolic alkalosis. What to do in metabolic alkalosis? Of course, you should treat the causing factor, but do not stop the compensatory hypoventilation. Correction of deficits of chloride, potassium, magnesium, and renal losses of hydrogen ions. Infusion of normal saline can be as first stage. Correction of potassium is very essential in metabolic acidosis because the kidneys cannot reabsorb the H ions in hypokalemia. There is a nomogram by Zygarde Anderson you can use for reading the analysis of acid-base balance. On the horizontal line, you should find the pH of the patient. On the vertical line, bicarbonate concentration. And when these two lines intercept, you can be oriented respiratory or metabolic disbalances, even acute or chronic states. Red lines indicate PaCO2. Thank you for your attention. If you have have some questions, you can read in chat or verbally answer me. There is two websites addresses. The first one, I'm using anesthesiology. It's our family site where you can find many information on anesthesiology and intensive care, including the PDF variant of this presentation. The second one is my YouTube channel where you can find the video of this lecture. Once more, thank you for your attention.